Hello, my name's Margie Taylor and I'm the Chief Dental Officer for Scotland, and today I'm going to be talking to you about the Oral Health Improvement Plan. This was issued in January of this year, and as you can see it covers quite a lot of topics. And what we intend to do is, as the title would give you a hint of, is to improve the oral health of the people of Scotland. Quite often we ask what our aim in life is and what our function is. And it's clearly improving the oral health, but we have some guiding principles. We want it to be as evidence-based as we possibly can. That's not possible without absolutely everything, but it's possible with quite a lot. We know that everyone deserves to have good oral health, and this is the quote from the WHO, which supports that. And we are guided by proportionate universalism. And that's really a complicated title for saying that we need to do what's necessary depending on the needs of the population. We appreciate that general dental practitioners will be the mainstay of providing services for the whole population, but they can't do this without the help of the hospital dental service and the public dental service, who play a vital role. What we want to do is meet the needs of the community regardless of their background, whether they live in a deprived area or a well-off area, whether they live in rural areas or urban. And very importantly, we want to put this matter on the agenda of others. So, about 10 or 12 years ago, access to dental services was very difficult. We do remember stories of people queuing round the block to get into a dentist, and the work that's been done since the last Dental Action Plan came out has largely addressed that, although there are still some pockets that we have to address. We can see from this graph that the workforce has increased substantially over the last 10 years. And most areas in Scotland, there isn't a problem getting access to a dental practice. But there are some issues that we still have to address, and that's prevention, inequalities, services for older people, and above all, we want to manage the change so that there is sustainability for dental practices. So what we're aiming for is evolution, not revolution, to bring about the kind of service that suits practitioners, but also provides the necessary service for patients and the public. So what have we achieved in the last decade or so? You can see that this graph shows that the primary 1 children with no obvious decay has increased substantially over the last 10 years. And if we look at the average amount of decay, we can see, as you would expect, that to have come down significantly too. And if we look at the slightly older children in primary 7, we see the trend that 77% of the primary 7 children now have no obvious decay experience. And we asked Glasgow University if they would do an economic evaluation on the toothbrushing programme that we had. And the blue section on that graph shows that the cost of the programme over several years. And the green part of the graph is the savings that we would expect to accrue as a result of having prevented the disease. So, if we hadn't prevented the disease, there would have been £4.7 million more spent on treating it than if we have prevented it. We can see that reflected in the number of children's fillings going down and the number of extractions in children having come down as well. However, we do still have a public health problem. If we look at the top 10 reasons for admitting a child to hospital for general anaesthetic day cases, then we can see that the dental column at the left-hand side there is significantly more than the rest of the causes. So it's still the single most common reason to admit a child to hospital for general anaesthetic. But on the positive side, we can see that the registration with a dentist is really quite high amongst most age groups. But it does tail off as somebody gets older, and if you look at the percentage of 75 years and over registered with a dentist, then we can see that about 20% are not registered with a dentist. So we are a bit concerned that they're not getting the care that they should. We've never had so many older people, we've never had so many older people who are frail, and we've never had so many older people who are frail and have their own teeth. So that combination means that this is uncharted territory, but we really will have to make sure that the older population, who are increasing substantially in number, are able to get their care, but also we need to prevent as much oral health problems in that age group as we can. What we can see here is a slide showing the numbers of people in Scotland who are registered with a dentist, and we can see that that number has grown substantially. The top line is the total, and the other lines are made up of the adult population and the child population. And that's all very well, but if people are registered but not attending, then that's not much use. So we introduced a measure called participation, which is looking at the percentage of people who are actually attending the dentist. And you can see there are two lines going up from the left to the right here, and they're both increasing. And we can see that that's the numbers attending. The line that's coming down is the percentage of participation. So that is the percentage of people who are attending within the last 2 years. And we can see that line's coming down. So the total number of people attending continues to increase, but there's something happening with the participation rates. And we don't know entirely why that is. We don't know whether the people who are registering now are irregular attenders, or whether it's just a manifestation of the rate of increase of registration. So that's something we would be interested to hear from practitioners, why they think that is. So, one of the most important subjects is prevention, of course, and water fluoridation is very high up and as being an effective means by which prevention can be brought about. There is a bit of a dilemma though, because water fluoridation, although in theory effective, in practice it's very difficult to introduce. So what we've decided to do is pursue other ways of prevention that we know work, and clearly we've shown that already in relation to child smile. We'll continue to monitor that, particularly in the older age groups, just to make sure that the progress is continuing. We want to introduce an oral health risk assessment so that practitioners can gauge how often a patient needs to attend the dentist. There are one or two myths emerging about regular attendance, but it could be that in the future patients may not have to attend as regularly as they have had to in the past if they've got good oral health and fewer risk factors. But at the other end of the spectrum, there could be patients who need to attend more often, and we want to be able to accommodate that too. We know that periodontal care is an important issue, and what we want to make sure is that patients with periodontal disease get their treatment in the future. And another important aspect is the possible contribution that dentists can make in relation to general health. For instance, if somebody is diagnosed as a diabetic, they get told to go along to the optometrist, they get told to go along to the chiropodist, but very rarely do they get told to attend the dentist, and it's very important. And likewise, dentists may well be able to pick up diabetics before they're formally diagnosed and refer the patient to their medical practitioner. So there's a symbiotic potential relationship there that might well help the general population. I think dentists are the service that people most often attend when they're healthy. So your average, for instance, 40-year-old male who's healthy very rarely goes to the doctor, but the likelihood is that they'll attend the dentist regularly. So if there's a way that the dentist can contribute to picking up diseases early, then I think that's something that we need to explore. The subject of reducing inequalities has been one that's vexed us for quite some time, and not just in dentistry. We know that if you live in a well-off area, the likelihood is that you will be much healthier than if you live in a poor area. And similarly, in relation to dental health, this slide shows mainly 5-year-old children, and at the right-hand side it shows the percentage of children in the least deprived areas who have no obvious decay. But at the left-hand side we can see the percentage in the most deprived areas, and there's a big difference between the people in the least and the most. Now, encouragingly, we have improved the dental health of the people in the most deprived areas through Child Smile. And there's been a lot of help from a lot of people, from nursery nurses, health visitors, dental practitioners, and the oral health team widely, and the dental health support workers. So that's why they have improved. But you can see that they still have to improve a bit more to catch up with the people in the least deprived. And if we look at the primary 7 children, then the pattern is exactly the same. So it's great that they have improved, but you can see that there's far more that we need to do. So what we're proposing in the Oral Health Improvement Plan is to introduce community development, and we've announced a Community Challenge Fund, and we will be engaging with the third sector to make use of that fund in the best way possible. We want to make sure that practitioners seeing patients from deprived areas are not disincentivised to do that. And for priority groups, we recognise that there will need to be shared care, possibly shared care between the public dental service and the general dental service. I spoke earlier on about the ageing population, and the number that we have in care homes now is increasing, and the people in care homes now are more frail than the people that we used to have in care homes, and sometimes they can be challenging to treat. So if somebody is suffering from dementia, they may not know where the pain is coming from in their mouth. They may find it very difficult to cooperate with treatment, and it's quite difficult for a dentist, without being surrounded by all the equipment that they usually have, to care for them. So what we want to do is try and prevent as much disease in that group as we possibly can. But if they do need care, then we need the dental practitioners to be experienced enough to be able to undertake that care. And we recognise that not all practitioners will feel comfortable about that, and we'll be offering some training for them. We also know that there's a lot of patients in their own homes who may not be able to get to the dental practice. And we have to have a system whereby the dentist knows that the patients are no longer attending for that reason, and make sure there's some domiciliary care available. But that really complements the care that's given to the people in the care home by those caring for them every day. And we'll be engaging with the care inspectorate to work with them to make sure everybody knows the best way to help the people in care homes. One of the innovations that we've been talking about is to try and ensure that as much care as can happen happens as near the patient as possible. And there may well be some items that are currently done in secondary care that could be just as easily provided in primary care. And although some will have to be done by specialists, there will be others that could be done by general dental practitioners who have shown a particular interest and have the experience, and we'll be developing a system of accreditation to help them to provide a service in primary care which will be nearer the patients. I think improving information for patients is important. The Scottish Government has a Make It Easy strategy, and we will be trying to ensure that patients attending the dentist understand as much as possible about what's going on, what the charges are. But I think we also need to simplify the item of service. There are, strangely, over 400 different things that somebody can do to your mouth. And that seemed to us and to many other people to be quite excessive. We narrowed it down to these ones as major categories, and these stand for oral health risk assessment, periodontal care, fillings, dentures, orthodontics, endodontics, crowns and bridges, and minor oral surgery. And what we would like to do is make the whole system a bit simpler. But what we don't want to do is destabilise the system as we do it. So we would want to discuss with the profession the best way of doing this, and I suggest that it would be incrementally, gradually, evolution, not revolution, to make it easier for the dentist to work in the system and more understandable for the patients. Quality improvement is clearly a very important topic. And at the moment we have quite a strong quality agenda. We're going to be having a national framework for quality assurance and improvement across NHS dental services, and that's been in development for some time. We're going to introduce protected learning time so that the practice can actually close and work within the practice or with other practices and clusters in order to help improve quality. We're going to appoint directors of dentistry in each of the boards, so there's one person in each board who's responsible for making the whole thing work. We're going to introduce a system whereby practitioners with problems are supported. We know that everybody in life can have problems, and that may mean that the quality of the care could diminish occasionally. And we want to be able to highlight practitioners who may have problems and help them in an early stage. But if they have to go through some disciplinary process, we want it to be proportionate and we want it to be local. And only those who need to be sent to the General Dental Council should actually end up there. We've been working with the practitioners to develop a system, and we're going to introduce that very soon. Practitioners will be familiar with the Dental Reference Officer service, and during the consultation we asked people how they thought that could be improved, and one of the suggestions was that the DROs might visit the practice. So what we're doing is giving that full consideration, and we'll be coming back to the profession with suggestions about that in the future. So as far as the workforce is concerned, we've seen an increase in the workforce over the last decade or so. We want to make sure that the right skill mix is there. We want to make sure that the dental care professionals are being used in the right way. And the increase in the number of older people may well be the best way of beginning that process, or beginning to extend that process. We want to make sure that people working in remote and rural areas are attracted there and are incentivised to stay there. We're not entirely sure what the impact of Brexit is going to be. We do know that in some areas we do have a lot of dentists from the EU, and we've relied heavily on them in the past, and we hope that they will be encouraged to stay. Time will tell just exactly what the pattern of European people coming over is going to be in the future. Out of hours care has been in place for quite some time, and we'll be reviewing that, but not in the near future. We're going to be having a GDP fellowship programme to encourage general dental practitioners to take leadership roles in the future and to develop their skills in other areas. We've just announced that there's going to be an occupational health service for general dental practitioners and their teams, and the widening access issue is an important one to us as well, and this is about recognising people from deprived areas can be just as smart as the people from the well-off areas, but they don't always end up in university doing the kind of courses that would give them the best start in life. So we want to see if we can encourage more people from deprived areas to be part of the profession. Finance is always an important subject, and we want to make sure that things such as payment verification systems are in place and are used properly. And we recognise that if we are moving services to primary care from secondary care, then some payment will be required to encourage people to be involved. So over the next few months, we're going to have to communicate quite a lot with the profession, and we've been asking them what the best way is to do that. We did have roadshows during the consultation process, and we intend to do that in the future too, but we recognise that we don't get to everybody. We have evening events across the country in the form of a small group dinner where the agenda belongs to the practitioners, and we hear what's happening at the toothface, and that's been very helpful. But there are some groups that we are particularly eager to communicate with, and that's the young dentists, who not many of whom came over to the roadshows, and part of that was because so many of them were too humble, really. They didn't really think that they had an opinion to offer. But we really want to hear from the young dentists, because the system that we're developing is going to affect them more than any other dentists. We want to make sure that the practitioners from the EU know that we're keen to listen to what they've got to say, and we're going to be setting up a network for them. And similarly, we need to know what the issues are that are affecting practitioners and their teams in the remote and rural areas. And we're also, in relation to the patients, working with the Scottish Health Council to develop a patient forum. I don't particularly like putting pictures of myself up on the screen, but this is just to remind me that we do have a Twitter feed. And we asked various dentists and staff and dental care professionals what the best way of communicating is, and many of them said that Twitter was important. We do have now, that's a slightly older slide, but we do have now over 800, but very few dentists following us. So we asked the young dentists what the best way of communicating with them would be, and they said Facebook. So we now have a CDO for Scotland Facebook page, and we'll be using that to communicate all the important things with you over the next few months.